So, good evening, everybody. It's time to start this symposium. It is really a pleasure for me to chair this symposium because we have a very interesting scientific program with very well-known experts in the field. It is also a pleasure for me to welcome the colleagues who are connected to this symposium via the web. This meeting is widespread all over the world through the webcast, so a welcome to all the people around the world who are watching this symposium. The first part of the symposium will be, which you see on the program, it's called Time, will be on the Levosimendan in different settings. We have two major experts, Professor Matthias Herringlake and Professor Sven-Erik Riksten. It is really a privilege for me to introduce the first speaker, Professor Herringlake, from the Department of Anesthesia and Intensive Care Medicine of the University of Lübeck in Germany, who is going to give his talk on perioperative effects of Levosimendan in CABG. Please, Matthias.
Dear Fabio, thank you very much for the kind introduction. Dear colleagues, I'm really astonished that so many people are interested in the topics either Levosimendan and DEX. Congratulations for staying so long in this meeting here. And within the next 15 minutes, I will have the opportunity and the privilege to discuss with you some issues of the treatment of the high-risk CABG patient. And by this, I will first go in the question, how shall we treat these patients optimally? And we'll try to elucidate that Levosimendan does indeed play an important role if you want to reduce mortality and morbidity in these specific population. Because most of you are familiar with comparable outcome data, and if you look for the left side, CABG seems to be a simple problem. Low mortality, acceptable mortality, whatever you call these 3%. But if you go a little bit more into depth in the details, and you look for the mortality in patients that present with a reduced left ventricular ejection fraction, you see the mortality is much higher. And this is also an effect we see not only for the short period of hospital mortality, but also for the long run. If you look for the long-term mortality in patients with reduced ejection fraction undergoing CABG. Interestingly, on the other side, these are the patients that benefit most from the CABG procedure itself, as has been shown in the STITCH trial. If compared to medical patients, you see that the long-term mortality in CABG patients is tremendously reduced. But in this initial period, there's the problem. And the problems in these patients may be related to the fact that they frequently present with low cardiac output syndrome and that they frequently use inotropes for this low cardiac output syndrome. Since we know that the low cardiac output syndrome in the CABG patient itself is associated with increased mortality, higher postoperative complications like myocardial infarction, an increased risk of AKI, as well as pulmonary problems. So if we want to avoid problems in these patients, it's probably not a bad idea to focus on the reduction of low cardiac output syndrome in this specific population. And we have to think about if our conventional measures to treat these patients by inotropes are indeed really appropriate. If we look for systematic reviews or papers focusing on the comparison between inotropes, vasopressors, and the optimal treatment in these patients, we frequently see sentences like these. The use of inotropes is associated with poor outcomes, higher morbidity, higher mortality. And if we go into specific studies, it is clearly detectable that if you use a conventional inotrope, in this study this was mostly dobutamine and PDE3 inhibitors, also epinephrine in a few patients, that if you treat them perioperatively, starting in the OR and extending this treatment into the ICU, is associated with a tremendous increase in mortality. This is also true if you treat them post-operatively. A short treatment in the OR seems to be not that tremendous, deleterious, but it has obviously an adverse effect. Is this astonishing? By means, no. Because if you use a beta mimetic in a patient with a coronary artery disease, of course, you will see an increase in myocardial oxygen consumption, a decrease in lactate extraction, and probably some sort of ECG depression in these patients. And if you use higher doses, you will even see a decrease in the shortening fraction. That means the heart begins simply to contract less. Consequently, these may probably not be the optimal choice to treat patients. But to extend the problems of the beta mimetics, it's maybe helpful to look for some lab data on the effects of beta mimetics on inflammation. These are cardiomyocytes treated with norepinephrine. Okay, it's also a beta-1 agonist. And what you can see is upon treating the cells, the myocardial cells with the norepinephrine, you see a tremendous increase in interleukin-6 expression in these cells. This can be blocked by a beta blocker. That means you increase inflammation by treating patients with a conventional beta mimetic drug. And by this, it's really not astonishing that, like depicted in the shock trial, that the mechanical problem itself may further be aggravated by an inflammatory response, ultimately more or less leading to a severe hyperresponsiveness of the vessels, vasodilatation, ultimately aggravating the mechanical problem of the heart. And to extend this concept further, it's obvious that an increased production of inflammatory mediators induced during a cardiac procedure, either myocardial infarction or a cardiac surgical procedure, may trigger either an increased sympathetic tone and a high inflammatory response, ultimately leading to distant organ dysfunction. And if one organ fails, you end up by inter-organ crosstalk in a combination of failing organs, from the heart to the kidney, back to the lungs that are filled with too much fluid, with an increase in pulmonary artery pressures, and again leading to a further decrease in cardiopulmonary function. Actually, a vicious circle that may kill our patients. The question is, can we avoid this if we use Levosimendan, especially in the population of cardiac surgical patients? Most of you are familiar with this drug, and it's interestingly more than an inotrope. It's also a drug that has cardioprotective effects by activating ATP-dependent potassium channels, but it's also a vasodilator. And these triple effects are especially interesting because in comparison to a conventional beta mimetic, we don't see an increase in myocardial oxygen consumption. This has been shown in healthy volunteers. This has been shown in patients with heart failure. We can accept that this drug does not lead to these problems we see with a conventional beta mimetic drug. But it works as an inotrope. As shown in this study, in comparison with milrinone as a PDE3 inhibitor, you see a prolonged increase in stroke volume index, also extended up to 2 days post-operatively, totally different to the picture you see with milrinone, and you see that you need less additional vasopressors. Same picture, same, more or less same results, different study. Patients treated with a bolus of Levosimendan immediately when the patients went on pump, but before aortic cross-clamping. And you see an increase in cardiac power. That's the product of cardiac index and mean arterial pressure, prolonged up to, in this study, 1 hour, accompanied by this cardioprotective effect, a reduction in the troponin levels. And additionally, a significantly reduced effect on the additional need for inotropes and prolonged use of inotropes in this situation. And a bundle of studies up to the last year have shown that these effects can be demonstrated if we pull them together in meta-analysis. It's the only drug that has 5 meta-analyses up to 2013 that showed beneficial effects in reducing mortality and morbidity in the patient cohort of cardiac surgical patients. But most of you are aware that levosimendan has been challenged, more or less, by 3 publications that were published within the last year. And we'll go a little bit into the details of these specific studies. The first one, using levosimendan preemptively in patients undergoing cardiac surgery, is the French LICON trial. And the colleagues used a dose of 0.01 mics per kilo per minute of levosimendan, started immediately after induction of anesthesia, and continued this treatment for 24 hours. And they used a combined endpoint of a catecholamine use beyond 48 hours, the need for mechanical assist, and the need for renal replacement therapy. Of note, and this is really important to interpret this data correctly, look for what catecholamines they included into the study. They used dobutamine, epinephrine, norepinephrine as an inopressor or milrinone. The results were neutral up to beneficial. There was a trend towards a reduction in the primary endpoint, but this did not reach statistical significance, mostly driven by the catecholamine infusion. And now think about the patient being on high-dose epinephrine, high-dose milrinone in severe circulatory failure, and a patient more or less scheduled to be transferred to the ward with the lowest dose of norepinephrine that is already necessary to have a wonderful blood pressure. Both patients fulfilled the endpoint. So this study has at least some sort of problem. What about the next trial? This is the large multi-center US-Canadian Levos-CTS trial. Roughly 850 patients were prospectively included in a placebo controlled fashion. 2/3 of these patients were CABG. The other patients were mixed procedures, CABG plus valves, mitrals, or aortic valves. The treatment was a little bit different to the LICON study in this way that there was a 1 hour of a slightly higher dose, 0.2 mics per kilo per minute, and then continued with 1.1 mic per kilo per minute for 23 hours in comparison to placebo. The results were rather neutral. There were 2 4-component endpoints that were analyzed, showing no significant difference between the patients treated with levosimendan as well as placebo. And the individual endpoints also showed no statistical effects. Only the secondary endpoints, like a reduction in low cardiac output syndrome and a reduction in the use of a secondary inotrope beyond 24 hours, were statistically significant. The outcome regarding 90-day mortality, again, a numerical trend, but no significant effect. Nonetheless, if these data, the LICON as well as the Levos-CTS data, are pooled into a recent meta-analysis, the beneficial effects of levosimendan remain. But it's especially pronounced in patients with a reduced ejection fraction. In these patients, we also see a significant effect on long-term mortality as well as on kidney failure. But regarding the specific population we are addressing today, or this evening, we did a secondary analysis, a priori defined, in patients undergoing CABG. And most of the results seen in the secondary effects regarding the reduction of low cardiac output and the reduction in the use of secondary inotropes were driven by the CABG population. And indeed, in this specific population, the isolated CABG, there was a significant, highly significant reduction in 90-day mortality. So actually, the drug worked in this specific CABG population. But there's another trial, the CHEETAH trial. And some of you may ask, okay, why didn't this work? It's rather simple. These colleagues included mostly patients with low cardiac output syndrome on the ICU on high-dose beta-mimetics. And if we go into the lab, we know that the effects, the inotropic effect of levosimendan is blunted if you pre-treat the muscle with a beta-mimetic. So it's totally, it was to be expected that in the CHEETAH trial, levosimendan could not work. And the second point may be simply that the dose that was given was clearly not sufficient, because if you look for this Italian study showing a significant effect on cardiac power index and a significant inotropic effect, they used roughly 2 milligrams before cross-clamping. If you look for the cheetah trial, these are homeopathic doses. Also in a Lycon trial, the doses were probably too low to achieve an adequate inotropic effect. And thereby, I'd like to conclude that despite the CABG population, the high-risk CABG population with a low ejection fraction has a substantial benefit from this procedure, we see that these patients have a high morbidity and mortality risk, and probably mostly related to the fact that these patients frequently develop a low cardiac output syndrome. Our conventional inotropes are not an appropriate approach to treat this because it increases myocardial oxygen consumption, increases sympathetic tone, inflammation, and mortality. And in contrast, we know that levosimendan as a calcium sensitizer does not have these deleterious effects on myocardial oxygen consumption. In contrast, we see an increased contractility but lower troponin levels and a reduced incidence of low cardiac output syndromes. And additionally, a benefit regarding long-term mortality in the high-risk patients with a low ejection fraction. But we have to take into account we should not use this drug if we are already working with high-dose beta-mimetics because we blunt it, we antagonize the effects, and we won't see any benefit for our patient. And we have to take this into account that the drug needs a certain dose before it works. Thank you very much for your attention.
Thank you very much, Matthias, for this very interesting presentation, which is now open to questions and comments. Any question from the audience? Any comment?
Thank you for your nice presentation. One question, very simple. What is the rate of low cardiac output syndrome in your patients after CABG?
In the patients presenting with an EF below 30%, the estimated range is around 25%. Yeah.
Any more questions? There is one here, please.
Just in regard to the blunting of the effect of levosimendan by beta agonists, is that just a class effect, or what's the mechanistic? Why does it happen?
Actually, I was afraid you would ask this question. It's probably related to the calcium sensitizing mechanisms. It seems to be disturbed if the muscle strips are pre-treated with a high dose of the beta-mimetic. I don't know the exact intracellular mechanism. But it's related to this specific class, because if you compare it with a PDE3 inhibitor, you don't see this effect. It's related to the calcium sensitization mechanism.
So is it okay if I continue the question? So if somebody is already on epinephrine or isoprenaline and you wanted to give them levosimendan, so what do you suggest we do? You take a higher dose, don't give it?
Actually, I tried, it's ideally to avoid the high-dose beta-mimetic, and you can do this simply if you try to identify the patients that are at risk and to treat them ideally before surgery. That means on the day before surgery, then you also can blunt a little bit the vasodilatory effects of this drug. Something we do on a routine basis. If we have someone, for example, combined mitral CABG with a low ejection fraction. And the second point is, if you are facing such a patient, for example, before CPB, someone comes on as an emergency case with high-dose epinephrine, high-dose norepinephrine, you should try to get rid of these substances during CPB and use as highest doses of non-adrenergic vasopressors you can use. For example, we use vasopressin in this situation. We taper down norepinephrine and epinephrine during CPB and give them a long period of washout, more or less, like an experiment. If they're still extremely tachycardic, I even add a beta blocker to reduce sympathetic tone. And then, in parallel, I start levosimendan. And of course, these patients need mostly a rather prolonged period of reperfusion. But during this reperfusion period, if you give the patient enough time, you frequently can avoid any further mechanical assist or other things. You simply have to give them time, and then levosimendan will work.
Matthias, I have one last question for you. I am sure that many people in the room have this question in their mind. Why do you think the drug did not work in the other cardiac patients, for example, in the complex cases?
I assume that there may be two explanations for this. First, if you think of a conventional, simple combined mitral valve case with one graft, you have only a few minutes for harvesting the graft, and then you go on pump. So the actual dose that was supplied to the patient was relatively lower than in those patients that underwent complex graft harvesting. Simple dose effect. A second thing may be also related to this blunting of levosimendan's effect of the high, the sympathetic tone and is extremely high. Ralph Schmeter, the first author of the LevoCTS trial, has done some studies in patients with mitral valve disease, and he shows that these frequently have an extremely high sympathetic tone, high adrenaline and norepinephrine levels. And by this, we may also see some sort of blunting of the effect beyond some other habits like mitrals are treated routinely with epinephrine in an institution. Another alternative explanation.
So would you agree with me that there is room for improvement in the way we use the drug and probably in the modality of delivering the drug?
Of course, I think the most important point will be pre-operative treatment, and ideally we have the privilege in Europe to do this in another fashion like in the US, because there the patients enter the hospital more or less by leaving the car in the parking lot and going up to the OR. And in our institutions, mostly the patients at least arrive on the day before surgery. And if you have someone who has a reduced ejection fraction, it's probably appropriate to treat him preemptively with levosimendan, starting immediately if you detect him, and then you have 12, 16 hours before the surgical procedure, and then it's easy going.
Okay, I thank you very much, Mattia. So it's now really a pleasure for me to introduce the next speaker, Professor Sven-Erik Riksten. He's the chair of the Department of Anesthesiology and Intensive Care Medicine at Sahlgrenska University Hospital in Gothenburg, Sweden. He's going to talk on renal effects of levosimendan. Please, Sven-Erik.
Well, thank you very much, Fabio. I would like to start to thank Orion Pharma for inviting me to give a presentation on levosimendan and the kidney. Before I do that, I would like to disclose that I have received lecture fees and travel support from Orion Pharma. Almost all inotropes, they are very potent vasodilators, and therefore we call them inodilators. So they don't only increase cardiac output, but has also the potential to improve organ perfusion, such as, for example, renal blood flow. But it's not immediately evident that the inodilators improve glomerular filtration rate. It depends on how each inodilator acts on the renal vascular bed. I will try to illustrate that on the following schematic drawing of the intrarenal, hydro, and hemodynamics. So we start out here in the aorta. You have a blood pressure, a mean pressure of around 100, and there is a blood pressure fall along the preglomerular resistance vessels down to the glomerulus, where you have the filtration, and then you have another postglomerular resistance section, also called the efferent arterioles, and down to the capillaries, where you have the tubular sodium reabsorption. So now, if you introduce a vasodilator that acts preferentially on the afferent arterioles, you will increase flow, and the pressure drop along the afferent arteriole will decrease, so the blood pressure in the glomerulus will increase, and also glomerular filtration rate. But on the other hand, if you have an agent that acts only on the efferent arteriole, you will increase flow, but upstream pressure here in the glomerulus will decrease. So glomerular filtration rate will decrease if you only have an efferent vasodilation. And if you have an agent that dilates both on the afferent and efferent arterioles, flow will increase a lot, but there will be almost no effect on glomerular filtration rate. Over the years, we have used the renal vein retrograde thermodilution technique for measurements of renal blood flow in patients in the ICU and also in the operating room. It's introduced here in the femoral vein and guided up to the renal vein by fluoroscopy. And with this technique, we can measure renal blood flow. We can also infuse a glomerular filtration marker, such as, for example, chromium EDTA, and make measurements on glomerular filtration rate. I have summarized that in this slide. You measure renal blood flow intermittently. You take blood samples from the renal vein and artery for chromium EDTA and oxygen content. And then you can calculate renal extraction of chromium EDTA, which it's easy to show that that is the same as filtration fraction. That is the relationship between filtration and renal plasma flow. And if you have that, you can calculate glomerular filtration rate. And of course, you can calculate oxygen consumption, taking flow times the arteriovenous oxygen content difference. And importantly, you can also measure the renal oxygen extraction, that is the arterial oxygen content minus the renal vein oxygen content divided by the arterial oxygen content, which is a direct measure of the renal oxygen supply-demand relationship. So if renal oxygen extraction goes up, it means that the oxygen supply-demand relationship has been impaired, and vice versa. This slide shows the relationship from our studies between glomerular filtration rate and renal oxygen consumption. There is a close correlation, and that means that if you increase glomerular filtration rate, more sodium will be filtered, reaching the tubules, and that will stimulate the sodium pumps to increase reabsorption and thereby oxygen consumption. So the major determinant of renal oxygen consumption is the glomerular filtration rate. So if you would like to increase GFR by an agent, you will also increase renal oxygen consumption. So therefore you need an agent that also increases renal oxygen delivery to meet the higher metabolic demand from the increased filtration rate. This slide shows the renal effects of low-dose dopamine, 2 and 4 micrograms in post-cardiac surgical patients, completely uncomplicated using this technique. And you see we have pre-drug measurements, 2 and 4 micrograms, and you see here renal blood flow increases 40-50%. In this study we had 2 independent techniques for measurement of renal blood flow, the infusion clearance and the thermodilution. You see almost no change in the filtration rate. And if there is no change in filtration rate, there should be no change in renal oxygen consumption. And now we have a situation with increased flow, no change in oxygen demand, which means that now we have a luxury perfusion. Renal oxygen extraction goes down, but we have no effects on the function of the kidney with dopamine. And then we can place dopamine here on the schematic drawing. They dilate both afferent and efferent with a pronounced increase in flow, no change in filtration rate. What about levosimendan? We all know that it's a potent inodilator for treatment of acute heart failure, and there are several clinical reports indicating that levosimendan might increase renal function. So we set up a study to more in detail try to evaluate the effects of levosimendan on the kidney. This was a study we published some years ago. Now we evaluated levosimendan versus placebo on GFR, renal blood flow, renal oxygenation in post-cardiac surgical patients in the ICU, uncomplicated cardiac surgery studied in the ICU, mechanically ventilated and sedated. 15 patients in the placebo group, 15 patients in the levosimendan group, starting with a bolus followed by the lower dose of levosimendan. We measured systemic hemodynamics by pulmonary artery catheter and all the renal variables that I described before. And as expected, there was an increase in cardiac index compared to placebo. There was a moderate increase in renal blood flow caused by a decrease in renal vascular resistance. And interestingly, there was a 20% increase in glomerular filtration rates. So our conclusion was that levosimendan acted on the afferent arterioles, increasing both flow and filtration. Renal oxygen extraction, which is the measure of the renal oxygen supply-demand relationship, increased slightly in both the levosimendan and placebo group, with no difference between groups. So what about levosimendan and the cardiorenal syndrome? That issue was addressed by Fedele et al. A couple of years ago. They included patients with acute decompensated heart failure with moderate renal impairment. Patients were randomized to placebo or levosimendan. They measured also central hemodynamics, and the renal effects were evaluated by the renal artery Doppler, and they estimated the glomerular filtration rate from serum creatinine using one of the formulas. So as expected, here is the placebo group, here is the levosimendan cardiac output index increased, filling pressures decreased with levosimendan. Renal Doppler measures blood flow velocity, but also the cross-sectional area of the renal artery. And as you know, the product of velocity and area will give you the flow in milliliters per minute, which they could calculate. And levosimendan in cardiogenic shock patients increased renal blood flow. They also calculated GFR from creatinine, which was increased over the next few days in the levosimendan group, and also urine flow on the right part of the slide. We have recently performed a study where we now have compared levosimendan versus dobutamine on the renal function, measuring glomerular filtration rate and renal blood flow and oxygenation. These patients were in chronic heart failure. They were evaluated for heart transplantation. They have severe heart failure, NYA 3 on 4, depressed left ventricular function, and they also, which was one of the inclusion criteria, impair renal function. They had the cardiorenal syndrome. They were randomized to dobutamine or levosimendan, bolus plus the lower dose. We measured the cardiac output and central hemodynamics, and as well as the renal variables. In this study, we didn't use the thermodilution technique, but instead we measured the renal plasma flow by the infusion clearance of para-aminohippuric acid. Both drugs increased cardiac output. Levosimendan, dobutamine increased renal blood flow, both agents, and both agents induced a fall in renal vascular resistance. Here we have the individual data on glomerular filtration rate. Dobutamine, no significant change, while levosimendan increased the glomerular filtration rate. So it seems that dobutamine have a similar action as dopamine, an action on both afferent and efferent, increasing flow with no change in glomerular filtration rate, while also in this study, levosimendan seemed to act only on the afferent arterioles, increasing both flow and filtration. Both agents decreased renal oxygen extraction, which means that they both improved the renal oxygen supply-demand relationship. No difference between drugs. So here I have compiled data of cardiac index, renal blood flow, and glomerular filtration rate. And here you see that, if anything, dobutamine induced a more pronounced increase. It was not significant, but there was a trend. Blood flow increased to the same extent with both agents, but you see here with levosimendan there is a 23% increase in filtration, but almost no change in renal function with dobutamine. So I would like to conclude that levosimendan causes a renal vasodilation. It dilates mainly the afferent arterioles, which is in contrast to catecholamines like dopamine and dobutamine, and therefore it increases glomerular filtration rate. And this agent does not seem to have any adverse effects on renal oxygenation. Thank you.
Thank you very much, Sven-Erik, for this very interesting presentation. So, questions from the audience? Comments? on such an interesting issue.
Thank you. Indeed, very interesting presentation. Yeah, but what do you expect the mechanism of this effect of Levosimendan? You know,
Why does it act only on the afferent side of the arteries? Well, there are experimental data showing that Levosimendan acts preferentially on the afferent instead of the efferent. So, yeah, that's the only. I don't think it has been thoroughly studied, but clinically it seems to work on the afferent arteriole.
Any more questions? Sven Erik, though it was, I think, the core of your lecture, may I ask you to underline, to make it stronger, that in patients with acute heart failure and renal failure, Levosimendan is to be used? Would you underline this?
Well, I think one conclusion is from our studies and also by the Fedele study is that it seems that Levosimendan is the only agent that in fact increases renal function. Dobutamine and dopamine will only improve perfusion but not increase filtration rate. And then there is also a question regarding phosphodiesterase inhibitors like milrinone, for example. It has not been studied, as I have seen no study that I am aware of, but we have some preliminary data on the effects of milrinone, for example, on the kidney, and it seems very preliminary that it has the same effects as dopamine and dobutamine. It's no change in filtration rate, but that is very preliminary. But there is hardly any study on the phosphodiesterase inhibitor and the kidney.
Any other comment or questions? If not, we are going to close this first part of the symposium. Let me thank all the colleagues connected via the webcast and watching our symposium.